Hello friends, today we'll be discussing about my name is Dr. Vishal and I'm discussing today with one of my friends. He's a prosthodontist. He's based out of Austin, Texas. He's working currently. Hi Karnik, how are you today?
I'm doing well. How about yourself?
I'm also good. So today we'll be discussing one case each. I'll be discussing single implant placement with restoration as well as he will be also talking about implant placement only, right? If I'm
Mainly about implant restoration, though.
okay. So let's not waste our time and let's get started with the case presentation. I will start first and then you start, okay?
Oh,
All right, let me start sharing. Can you see my presentation?
it's loading up. Yes, I can.
All right, let's get started. So basically, before starting the implant placement, I will be discussing about the implant surgical component and then prosthetic components. So in the surgical component, as we know, we have implant body along with we have healing abutment, cover screws, and then in the prosthetic component, we have impression copings, which will be open tray impression copings, closed tray impression copings. We have analog, we have abutments, and finally we have crowns. So this is basically this is the gist of the implant dentistry. The implant body, will go into the jawbone. On top of that, we have abutment, and then finally we have crowns. So coming back to my anterior immediate implant placement. So this is the panoramic radiograph of my patient. So patient was complaining, the chief complaint of the patient was pain on chewing on number 7 area. There was grade 2 mobility. Along with that, patient had a generalized severe bone loss. Also, he had wisdom teeth present, which is number 1, 16, 17. Also, because of the generalized bone loss, I decided to plan for osseous resective surgery. As you can see in the PowerPoint slides, the sequence of the treatment. But today we'll be focusing on immediate implant placement number 7. So this is the CBCT slice of the particular area. As you can see, the red line showing the particular 7 number area with the CBCT slices. As you can appreciate from the CBCT slices, there's barely any bone left around number 7. So obviously there was a grade 2 mobility around that area, so decided to extract. As you can see, the palatal bone, the apical bone around number 7 area, where we could plan for the immediate implant placement. So these are the steps for the immediate implant placement. The top left picture is showing the smile line. Patient has a fairly low to medium smile line. Also, you can notice number 7 area as a discoloration. That's where the mobility was. Patient was not happy with the way he was smiling. The second picture is showing the atraumatic extraction. Atraumatic extraction in immediate implant placement is the key factor. The third picture is showing the osteotomy preparation with the 2.0 drill. It's showing the parallelism with respect to the adjacent teeth, and the last picture is showing the placement of the implant with immediate temporization. So immediate temporization was completely based on the torque value of the particular implant, and also made sure that there was no occlusal contact. So this is the immediate CBCT after the placement of the implant. As you can see, the slices showing the placement of the implant and the periapical radiograph. The proximal distance or the parallelism between the adjacent implant was pretty good. I was really happy with the placement. To be more precise or more critical about it, I could have been a little bit more palatal looking at the CBCT. So the next picture is showing the fixed temporary crown on number 7. Patient was really happy when he received the temporary fixed crown on number 7. He so that the thought that he didn't have to wear the partial denture. So he was pretty pleasant and happy with the temporary restoration that he received. So as I'm not a prosthodontist, but I also went ahead and restored this particular case. But as I broke it down into 4 stages in the prosthetic stages. So the first stage is implant level impression. So implant level impression could be open tray impression and closed tray impression. The second step in the prosthetic steps will be fabrication of the crown. The options will be cement written crown and screw written crown. The material of choice will be porcelain fused to metal, ceramic, zirconia. It's up to the dentist. The next step will be crown delivery, and the last will be recall appointments. So this is the after 4 months of osseointegration of the particular implant. So looking at this picture, I was really happy from the perio perspective. Looking at the amount of keratinized tissue surrounding that implant, that made me really happy. So the first step in the prosthetic stages will be implant level impression. So I went ahead and took the open tray impression. So the material of the choice that I used was heavy body material. So in the picture that I was showing the access channel for the impression coping. So in the fabrication of the crown, we have two choices: a cement written crown and screw written crown. In this particular case, I used cement written crown because of the aesthetic portion. Also, the material of the choices were porcelain fused to metal and zirconia. I'm pretty comfortable with porcelain fused to metal, so in this case, I used porcelain fused metal. So the next step is to communicate with the lab. So lab sent us a crown with the abutment and a jig. In the left side picture, they're showing the jig is actually manipulating and angulating the abutment. And once the abutment is in place, I took the periapical radiograph just to make sure the abutment was completely seated. Once the abutment was seated, I went ahead and torqued it down to the recommended value torque. In this case, I use Straumann neodent implant. The recommended torque value for the neodent implant is 15 to 20 Newton centimeter. So after immediate torque it down to the recommendation torque value, you can see the right side picture, the blanching of the gum tissue is pretty common. So that is very common. If you wait 10 to 15 minutes, the blanching will go away. Also, you have to wait for 15 to 20 minutes and again go ahead and torque it down to the recommended torque value. So this is the final picture of the after I torque it down the abutment. This is how it looked. As you can appreciate in the picture, the blanching of the gum tissue went away. So after torque it down, so I blocked the access channels, the abutment access channel with the either Teflon tape or cotton pallet. Once you block that, yeah, I went ahead and when blocked the access channel with the either flowable or packable composite. And after that, I cemented the crown with temp bond cement, as you can appreciate, and also made sure that there was no residual cement left, and took the PA just to confirm the seating of the crown, and also made sure on the PA that there was no residual cement left. Otherwise, it could lead to peri-implantitis. So this is the final smile once the patient received the porcelain fused to metal crown, and patient was really happy the way he looked. As you can appreciate, the interdental papilla is also preserved. This picture. So this is how patient walked in. As you can appreciate on number 7, the discoloration of the crown, and this is the picture when he received the final crown. As you can appreciate, there's a lot of difference between the two pictures. Patient was very happy, and so did I. So to conclude and to sum up my presentation, the case selection and treatment planning in the aesthetic implant placement is very, very important. The second conclusion is atraumatic and extraction and palatal placement of the dental implant. And the next one will be soft tissue preservation and maintenance of the papilla with the temporary crown. That also played a very important, crucial factor in terms of preserving the interdental papilla. The next step will be night guard delivery and regular follow-up appointment. I hope you like the presentation. And
Uh, Thank you for the amazing presentation. I have a couple of questions
sure, go ahead.
for your presentation.
Mhm.
So when you did the immediate temporary for the patient, did you have any certain specific restrictions as far as patient's dietary habits or anything like that, or
So
how
dietary
did you?
habit, definitely after the implant placement, we ask the patient to go on a soft diet at least for a week or so. In terms of the temporary, it's very, very important. I never promise my patients that patient will get something fixed temporary. I always keep the backup either SX or removable partial dentures. The decision that I make, giving the patient a fixed temporary restoration based on the torque value of the particular implant, and also once I achieve the particular torque value, then only I go ahead and give the temporary fixed crown. And then after that, I make sure that patient is not biting. It should not be in the occlusion in any of the protrusive or any of the excursive movement. That's
Okay,
the protocol that I follow.
I think you make a very valid point that, and I would like to I like our reviewers to kind of put extra emphasis on this point that it's very important that there is no centric, but there's also no lateral protrusive or excursive
Correct.
occlusal contacts on the temporary. Otherwise, you are basically accelerating the possible failure of an immediate
Very true.
implant,
Very true. Very true.
especially when it's in immediate extraction site where the implant is not yet healed, because I
Very
think
true.
important part is to.
If one is following all this protocol and making sure that there's no contact and protrusive as well as any excursive movement, the outcome, especially soft tissue outcome, will enhance, and that's what a periodontist or a surgeon will be looking forward to get the result, the kind of results that they are looking for.
Okay. Another question I had was that you said you like PFM, you like PFM crowns for and you're very comfortable with that.
Correct.
But have you had experience with you know okay, maybe yes. Okay, so how do you select, like, do you the material, the crown material, does it depend on the gingival biotype of the patient, or what
It's
are the
it's
two main
it's a
factors
very
that
good. Yes, it's a, and also in prosthetics, as you know better than I do, prosthetic has a variety of different types of material. As I'm still learning the prosthetic aspect, especially the different materials. So far, I've been using porcelain fused to metal, zirconia, and some of the ceramics. Not that many ceramics, but zirconia, especially in the anterior areas, I'm using zirconia. Posteriorly, I'm using porcelain fused to metal. But if I know I have to adjust the bite and I have to manipulate bite too much, then I will go with porcelain fused to metal, as it is much more forgiving in terms of if I need to make the occlusal adjustment or I need to adjust the bite. Porcelain fused to metal is much more forgiving than zirconia or ceramics. Okay, so on my presentation, I do have a question for you. As I said, I have a lot of questions about prosthetic. I'm still learning about prosthetics. So one question that I have is, luckily, unfortunately, my patient had a low smile line in terms of restoring the anterior implant area, but it can be very tricky. I'm very lucky and fortunate that the result that came out in this particular case. But let's say if the patient had a high smile line, would you change the material with the in terms of abutment selection as well as the porcelain fused to metal that I used? Would you do it something differently?
So let me kind of tell you how with my case, my patient had a relatively high smile line and it was kind of lopsided. So I
Mm-hmm.
think when it comes to cases like that, you have to kind of look at how the other teeth look like, and
Mm-hmm.
if the patient has a lot of restored teeth, then it's easier to use a PFM restoration, because it's very common to find PFM crowns in the anterior posterior teeth. But if the patient has mainly unrestored teeth, then
Mm-hmm.
and sort of the shade matching, I think we have the ability with zirconia crowns to get maybe a slightly better shade matching. So that is one thing that I think I would take a look at. And then the other thing, obviously, is the occlusion. If the patient has a deeper
So
bite.
you're saying the abutment, the custom abutment that you will order will be the material. Which type of material would you choose?
No, no, no. So this was my material of choice for the crown itself. For the custom abutment, if the patient has a high smile line, a lot of times I prefer a gold hue abutment.
Which
It's
abutment?
a gold hue, like titanium abutment, with which is oxidized to gold color, because
Okay.
that the shadow of the golden color, it looks more natural underneath the gingival tissue
That's
compared
a
to
very valid point. Yeah, that's actually, I'm still learning about this U chrome, and that's very important. It plays very crucial role in terms of when patient has a big smile line or high smile line. That kind of underlines the if patient is showing too much of gingival tissue, that will
right.
underline or that will cover um the color of the abutment basically.
Yeah, but yeah, and then one other situations where I also like the gold color if the patient has a thin gingival biotype, because those patients are prone to show the gray, and
Mhm.
especially thin gingival biotype and high smile line combination is probably the trickiest of the situations I have to consider. And for those situations, I also consider using a titanium base
Mhm.
with zirconia abutment. So the connection to the implant is still titanium, but then it's a very small line on top of the implant platform, and the rest of it is zirconia. So underneath the gingival tissue, it does not show the gray or any of these dark shadows.
Very good. Because of we are running a little bit out of time, so we'll have to stop taking the question answers at this point. But again, thank you so much. Really appreciate your presentation. And as I said, we'll come back with more cases. Stay tuned.
Sounds good. Thank you.